Good morning, everyone, and welcome to Global Neurosciences Institute Grand Rounds. We'll give a couple minutes here as there are a few more people circling in as we're just starting at 8 o'clock. As always, just if you need to get your credits in the chat room, Nicole Myers will be putting the link. So after the Grand Rounds, please complete the questionnaire and you'll get credit for this session. This morning, we are really happy and excited to have, I think I can say one of our own, Dr. Sam Zarbiv. Dr. Zarbiv received his MD and Master's of Public Health at our very own Drexel University College of Medicine. Went on to do one of the premier neuro-critical care fellowships in the country at Mount Sinai in New York City. And came from there to Cooper University, where he was in the neuro and cardiac ICU. And I think Atlanticare was fortunate enough to snag him here to Atlanticare. And I can tell you on a personal note, I think probably within the first 30 seconds of us talking to him when we first arrived here, we were like, okay, this guy gets it. So Dr. Zarbiv is now the director of the neuro-critical care here at City Campus in Atlantic City, which we are absolutely thrilled about. We've really kind of changed the whole look of the ICU and really we're in a different place now thanks to him. And this morning, what he's going to talk about is basically tenets of that and when complexity requires a team and specialization, subspecialty critical care. So really looking forward to this. And Sam, it's all you.
All right. Thanks. Thank you very much, Dr. Vez. All right. So I am going to spend hopefully the next 45 minutes just kind of giving a lay of the land here with respect to what I mean by subspecialty critical care, sort of what is critical care and how it applies to the to our patient population, specifically in the neuro ICU. My only disclaimer is that I love talking about this stuff. I could talk about this stuff for hours. And I tend to tell lots of stories, so bear with me. But I think ultimately this is going to end up ending in sort of the same way, which is what's the vision for the future. And I think one of the big appeals that I've had to Dr. Vez and to GNI is the vision, right? Is the vision, the belief in putting the patient first and actually living that. So we'll talk about just the objectives for today real quick. So the evolution of complexity within critical care. So as diseases like stroke or acute myocardial infarction become more and more prevalent, the need to sort of interact with your proceduralist colleagues, whether it's a neurosurgeon, cardiac surgeon, interventional cardiologist, all of these become increasingly important. And the only way the patient can ever really sort of do well for all intents and purposes, the only way to move the ball is as a member of the team. So we'll identify some opportunities in ICU care. So how can we sort of combine the specialty aspects of this? So how do we go above that sort of that medical ICU 24/7 general intensivist that was described back in the early 2000s, sort of take this to the next level and do this collectively? And then what's the role of subspecialty critical care and subspecialty expertise, if you will, as we sort of move forward to what I envision to be a tremendous opportunity here, which would be a center of excellence for neurocardiovascular care. So real quick, I think I gave I think I spoke about most of these. So I'm going to present a lot of statistics here and mortality reduction, things like this. A lot of this is just going to be coming from overall, a lot of AI actually, but looking at various studies, and none of them are great. They're all these studies looking at one center compared to the next. Obviously, you got to take those with a grain of salt. But I think by and large, I think what we see around us tends to be true, which is that patients who are profoundly ill with very sort of complex diseases, they just tend to do better when we work collectively as a team. And today I'm going to try and prove that. So just real quick, how I sort of got into this and everything sort of leading up to this moment, if you will. And like I said before, I got a lot of stories here. But when I was in college, everything in my life tends to be an epiphany. But when I was in college, I decided in, I don't know, first week that I wanted to be a physician, specifically a psychiatrist, perhaps because everyone's good at their own disease. I don't know. But sort of, then after a day of my psychiatry clerkship, that quickly changed. But I think that the underscores of that, the humanity of it, the speaking with patients, speaking with families, sort of the interpersonal connections that you develop within the critical care unit, to me was very appealing. So after med school, I took a year off. I did a combined MD-MPH program. My master's in public health was specifically looking at actually, creating quality improvement within actually rapid response systems at Hahnemann. So a very large hospital system with sort of very fragmented rapid response systems, and sort of what goes into quality improvement. How do you sort of track data, and what do you do with those data? So as Dr. Vest said, I did my medicine residency at Cooper, I did my general critical care at Sinai, as well as neurocritical care, returned to Cooper, and started to really to develop a passion for critical care program building. First at Cape, which is now Cooper, and then at Atlanticare in the cardiac ICU, which was back in April of 2021. It feels like eternity. And then in 2023, I'll tell one story here. I remember sort of it was a messy divorce from Cooper, and I remember talking to my wife about this decision. And it was late at night, and I looked at her and I said, I'd love to develop a division of subspecialty critical care. And she was like, what's that? Does that even exist? I'm like, I don't know. But it's neuro and cardiac, right? These are the sort of the specialties that require a lot of intricate work and very minimal room for error, if you will. We're going to talk about that today and why that comes into play here. So I just want to give everyone an overview. So what do I do? I'm an intensivist. I'm a critical care doc, right? My mother-in-law, she still thinks that I'm an emergency doc. My daughter is absolutely convinced that I should not be working with doctors who do stitches if I myself am not doing stitches. And I think that understanding sort of the what exactly goes into being what I consider a really good intensivist, right? The bread and butter, which is resuscitation, timely resuscitation. That's going to become really important, specifically with acute neurological injury. And I'd argue that more so than in the neurological injuries and in the cardiovascular injuries. And that's just because of the technology that we've seen with mechanical circulatory support. So very timely resuscitation, understanding and really being in love with hemodynamics, whether it's even cerebral hemodynamics, and sort of getting a very good understanding of what it is you're trying to accomplish with each specific intervention, whether it's vasoactives, blood, whatever the case may be. Mechanical ventilation and weaning from mechanical ventilation, which is actually something that I've been specifically interested in. Working on an app I'm going to show you guys. And then applied physiology, right? So the reality is that you have to have a really good understanding of what the physiology is. Number one, so you can actually take care of the patients, but also so that you can have informed conversations with your surgical colleagues, right? That's really the only way to move the ball. And so this is a quote from my old program director that kind of stood out, stuck with me for years. If surgeons, we do a lot of surgical critical care. If surgeons are like mechanics who fix broken parts, well, then critical care physicians are like engineers who keep the entire system running when multiple organ systems are failing all at once. And that's my daughter. She's super cute. So if nothing else, all right. So subspecialty critical care. So and this is just a sort of a brief overview of some of the stuff that we'll cover here. But and I'm actually not going to spend too much time on this slide here. I think we'll talk about all of these. But what's the foundation for critical care, right? What is the intensivist, right? You have to. So an intensivist, like I said before, hemodynamics, respiratory status, a master, if you will, of all the various organ systems and how they sort of interplay. And as I will get to, right, the mortality benefit of a neuro ICU is probably less likely to do with the brain, right? And I think that that's simply because of one, undeniable fact here, which is that the neurosurgeon has much more intimate understanding just based on the training alone, just based on the thousands of hours of work that goes into becoming an expert on this, right? So their understanding of sort of the neurological component of a neuro ICU is something that, not to say we don't have conversations, but it's always something that I'm willing to sort of, ask about and be humble with, right? But it's the other organ systems that are particularly important, right? It's maintaining adequate, renal perfusion, adequate liver perfusion, proceeding to tracheostomy in those patients that we all sort of know are probably not going to be successfully extubated, because the goal here, especially in the neurologically injured patients, is rehabilitation, and that's part of their treatment strategy, if you will. And it's something that I really think that our neuro ICU should and will spend a lot of time sort of really attacking, and specifically with innovation and technology. So the specialty applications here for cardiac ICU, right? So there's there is a 23% risk mitigation in postoperative cardiac surgery patients in a cardiac ICU, right? And that's simply because things like protocolization, communication, timely interventions. And one of the most fascinating things you're going to see in the literature is that the intensivist in a cardiac ICU is much more able to identify changes in the neurological exam. And I think that that's sort of something that really ties these two fields together. So the challenge of complex critical care is manyfold here, but I think the biggest challenge that I face and that critical care faces is that we're sort of, in all of medicine faces, where there's so many silos. There's this division, there's this consultant. There's all of these sort of sort of competing interests, if you will, and sometimes they are competing interests. That you have to sort of understand where they are and sort of realize that much of what we say has always been this way, well, probably shouldn't, right, and deserves to be questioned. So I think the silos are something that really are fundamental to being any good at critical care, right? Understanding where they are and breaking them down, asking good questions. But time-sensitive intervention here is to me, that's what's key here, right? So, I think that there are sort of these two, mindsets, if you will. You have the general intensivist, of which I am one, right? That closed ICU structure, I put in orders, these sorts of things. I found it to be very sort of not productive as far as moving the ball, specifically in our neurologically injured patients, right? I think where it becomes extremely sort of applicable here is the fact that, over a quarter of your neuro ICU patients with acute neurological injuries will actually have other organs that fail, right? And we know that with each additional organ failure that we have, the chances of surviving become smaller and smaller. Specifically, things like the mechanical ventilation, the use of ECMO, right? I didn't spend too much time, well, let me rephrase it. I spent a bunch of time looking at ECMO in acute brain injury. Didn't put too much of it in this presentation. It's probably a story for a different day. But sort of the more I dive into that, the more I realize the treatment strategy for ARDS in patients with subarachnoid hemorrhage, ischemic stroke, probably tends to be more along the lines of more aggressive BV ECMO. And sort of we'll allude to that later on. So what's the evidence to this, right? So what does the data actually show? And like I was saying before, these are sort of data sets and the studies that are comparing one ICU to the next, or registry data. It's very difficult to sort of conduct, your sort of gold standard, trial data when it comes to these things. But I think that by and large, what you see in a subspecialty critical care unit is a high intensity intensivist staffing, right? And so that's sort of where the mortality, it's believed that some of this mortality benefit comes from. I'll argue that it's just, being a good physician, getting along with people, moving the ball every day, right? Keeping track of what intervention you've done and what the outcome is, right? And then sort of bigger quality systems outcomes, things like length of stay, days in the ventilator. So what do we get in a subspecialty ICU? Is to get reduced average ICU length of stay, which is big, right? Especially in patients with acute brain injury. Those are patients that will benefit from not lying in their supine position waiting for a PEG tube. They benefit from early mobilization, right? Then things that sort of would apply to all other areas of critical care, but are specifically unique, I think, to the neuro ICU. I think it's something that we tackle, collectively. So, currently the model we have working in Atlantic Care, critical care, is this 24/7 sort of intensivist in-house coverage. I'm working nights tonight, right? And I'm sure at some point tonight I will get tired and I will think to myself, geez, what exactly am I doing here other than procedures that I couldn't really cognitively do either remotely with a robot or or just by supporting some of our teammates like APPs who are working overnight. And that's really the model that you see in a lot of specialty ICUs across the country. So I think that sort of moving or questioning, sort of, if you will, the thought process that sort of gave rise to this 24/7 coverage, this coverage model. And this is back in 2002 with Provenos, published a study in JAMA. Sort of, if we can improve the processes, therefore the outcomes must get better. And it turns out actually that's probably not true. That improving processes does not inherently guarantee outcomes get better. That the process might get better, but patients don't necessarily do any better, right? And I think that that's something for us to keep in the back of our heads. And then it's a very sort of labor-intensive model, right? We have 5 FTEs currently, right? It really does require 7 FTEs in order to be able to staff a critical care unit 24/7, right? Cost effectiveness, it's important, right? You got to keep the lights on, right? But I think that sort of creating the right in each of these, the right model, if you will, is sort of dependent on where you are, because the context matters, right? These are complex systems. These are, human dynamics, team dynamics, things that are really important to keep in mind, right? So when we look over here at the bottom right, right, so what does mortality show over the past? And this is from looking at data sets really over since this notion of these actually specifically through Leapfrog, actually, some of these quality movements, right? In-house 24/7 coverage. Well, does it reduce mortality? Does it reduce length of stay? Does it reduce ventilator days? And interestingly, the answer is maybe, and it depends, right? But it's not as slam dunk as you'd think, right? So let's just real quick go over the evolution of critical care, right? It actually, the first ICU was probably a neuro ICU, and that probably was a neuro ICU, and that makes sense when you sort of think about the history of medicine, right? The polio epidemic, the polio leading to the artificial lung, right? Critical care units were developed, and they were staffed by neurosurgeons, right? Same thing with cardiac surgeons, sort of as time will go on, right? But by and large, we don't really start to see critical care as we know it today as a fellowship, as an ACGME accredited fellowship, and certainly not the subspecialty critical care aspect. So when I did neurocritical care, it was actually not an ACGME accredited fellowship. It is now. And I think this is what's up and coming in the cardiac critical care space as well, right? So to be a neurologist that's managing a ventilator, I don't know. I will say that I think that the general critical care background that I have sort of made it my training in neurocritical care a little bit unique in many ways. An intensivist once said this: I don't believe this to be true at all. I do not think it's the presence of the intensivist that reduces mortality over the past 70 years. I think it's actually the development of, things like, mechanical thrombectomy for acute ischemic stroke. It's the advent of drug-eluting stents in cardiac in for the treatment of acute myocardial infarction, right? So teamwork and specialization, those are mandatory if you want to improve outcomes in complex disease processes, right? And I think that's where I find a lot of parallel processes, a lot of parallel lessons, a lot of things we take from the cardiac ICU and sort of deliver it into the neuro ICU. And I think that to me is what's exciting, right? It's sort of how do you deliver sort of these very complicated disease, how do you deliver care to these very complicated disease processes, then sort of break down that care, if you will, and then be able to sort of do it in service with a smile, if you will, right? How do you enhance the patient experience? How do you separate, how do you develop a program that separates sort of us from them, right? And I've always said this, and I truly believe it, we're not going to be a large volume center where, we're never going to be like Sinai with 25 floors in the Upper East Side of Manhattan. And we shouldn't try to be, right? What you get in our neuro ICU is an intimate environment, right? And I'm going to talk about a case that Dr. Bez and I had together back in August. To me, that was sort of this like, felt as though everything I had been working for sort of leading up to that moment, right? Case of a guy with a subdural. But that multidisciplinary approach to me, I always say you get 12 hours to a day, with all the nursing staff, with all your patients to really sort of dig in, and I think that's something that's important, in critical care. So neuro-critical care data emerging right in the mid 2000s I think that when we start to see this surge of neuro-critical care, neuro ICUs, it's a lot to do with the timing, if you will, to show the effectiveness of things like mechanical thrombectomy for the treatment of large vessel occlusions, right? And so you had a bunch of negative trials first, the technology gets better, and boom, right? The field is up and coming, right? And every day there's something that you can find online that's even cooler than the day before, right? Patients do very well because of this, right? And if you mess it up, right, patients will do really poorly, right? So and I'm going to talk about sort of how do you embrace what your colleague is doing and understand what they're doing so that you can do better by the patient, but also have an appreciation for what their risk benefit profile specifically is. And the parallel to that in cardiac critical care is really, to me, is in the early 2000s with the Manny Rivers trials, looking at protocolized treatment for septic shock, early goal-directed therapy. Whether you believe it or not, without that trial, I do not know that we have the field of critical care medicine as we know it today. Also in the cardiac critical care space, the advent of drug-eluting stents just absolutely revolutionized the way in which we treat acute myocardial infarction, right? And from there was just the technology took off, right? And it's been tough to keep up with. I would argue that one of the most important, the H1N1 influenza pandemic, which was affecting predominantly pregnant women, young, otherwise healthy people. That's where we saw this surge, specifically out of the University of Michigan with the use of ECMO. And I remember as an intern or maybe as a medical student in H1N1, sort of the widespread use of ECMO. I sort of think back to it and I'm like, wow, that's a really different, almost like a different, treatment strategy, right? It's just about the experience, right? So the multidisciplinary integration here is, the intensivist sort of, is to work with a team. It's not just us, right? It's your bedside nurse. And I always say you're only as good as your bedside nurse, right? So how do you sort of, include them, if you will, and sort of make everyone sort of feel that we have a common goal, a common vision, right? And we know exactly what it is we're waking up to do every day. We do it, right? Get better every day. I I did not spend too much time in this, but I think it's worth mentioning sort of the experience that we've had at Atlanticare with, specifically when it comes to cardiogenic shock. Right. So as I said before, the cardiogenic shock program that was started in April of 2021, we really did start. I did not start to track any data until 2022, and for the past, I would say, late 2023, 2024, 20, and now we actually are participating actually with recognition from the American Heart Association. Get with the guidelines in cardiogenic shock. And so you can sort of compare yourself to other places, but also it's eye-opening, right? As far as what exactly is the problem and how do you intervene on it, right? And so our experience at Atlanticare was initially, I remember every single time we'd put an Impella, which is a microaxial flow device, mechanical circulatory support, we had complication after complication, and many people died of these complications, right? And sort of how do you get better, right? And that really requires, number one, protocolization, right? Commitment to protocolization. And when you deviate from protocol, why are you doing that, right? So it's sort of like we all agreed on this. So why is this any different now, right? And I think that's a really important lesson for us to take to the neuro ICU. We had each year when you look back, we got better, right? Because you get better every day. We're not a high volume center. It's the quality of the care that we do, right? 2020, we saw a very significant drop off in mortality, both at mortality to explant, which is something the company gives you, right? So if the patients can, if you are doing CPR, but you take out an Impella, the company will tell you that survival, I will argue, is probably not, or things like 30-day survival, probably much more powerful. Sort of protocolization, right? So this is just one of the, and I'm not going to get granular as far as, right, but the commitment to sort of this, and they're the same everywhere, if you will, some sort of iteration of your, shock algorithm, right? What do you guys as a team, what do we all agree that we're going to do? And what do we agree we're not going to do, right? So this is what we've implemented. I think it's very successfully. It's been very rewarding in the cardiac ICU. These are specialty ICUs that really have very interesting parallels, right? The successful cardiac ICU and neuro ICU have a very sort of interesting parallels to why it is that they're successful, right? Mortality reduction, of course, right? But length of stay, probably more meaning. Less time on the ventilator, more time ambulating, more time, recovering from your stroke, from your brain injury. Subspecialty trained intensivists, protocolization, continuous feedback is so important, right? And then innovation and embracing technology and realizing that the industry that is sort of, that develops this technology, they're your friends. They're not at all something that we should be ashamed of, right? These are people that actually, these are companies that have common interests, right? Theirs might be financial, whatever the case may be, but it's good for patients, right? It sort of, and it brings everyone together to sort of talk about, things that can help a really complicated disease process. So, appreciating surgical, if this was not on Zoom, I would totally stop and be like, whoever gets this, that's not a neurosurgeon, I'll buy a drink, right? So if you look at the picture on the right, when I was looking at, my attention gets drawn to this segment right here, right? But what is all of this, right? And sort of this is, so if you look from the left, middle to right, but before and after, right? This is actually a case, again, a failure of sort of the escalation pathways for exam changes that led to Dr. Scullin having to emergently rebuild this to do really complicated and absolutely fascinating, intracranial work that you can actually there's things that that is sort of very it's very technically challenging in the coronary field, but doing it in the brain is something that really is phenomenal to me, right? So appreciating that surgical risk, appreciating the fact that I'm not the one who has to sort of go, who has in a pinch to realize, okay, well, with whatever equipment I have, I got to figure out a way to open up this little, what I call dental floss lesion, right into what you see here on the right. So I just want to, let's just talk about a case and sort of, and that way keeps me from rambling, but also sort of, I think in many ways the best way to sort of teach this. So back in late August, I got a call from one of the PAs over at Cape, but I'd known. He was calling me about a 52-year-old guy, very nice family, of course. He had a mechanical mitral and aortic valve. There's a redo done by Joe Baveri actually at Jefferson. So he was on Coumadin therapy, and he had a cold. He was taking cold medicine. He was sneezing and coughing a lot, and then he got a really bad headache. Right, all in the setting of an INR of 7.2. So he shows up to Cape, and he very rapidly deteriorates. He's now intubated. His exam quickly deteriorates to having some very obvious clinical signs of herniation syndrome. So we bring him over, and I remember getting the call, and I thought back to one of the project emergency transfer line. Right. So it's kind of, you get a phone call at 3 a.m, and it's someone who has intracranial hypertension or ICP crisis from whether it's a ruptured aneurysm or in this case, an expanding subdural. Right. Right. So what do you it's a 1, 2, 3, 4 walk and chew gum kind of thing. Right. So you got to give instructions of, and I'll say the same thing every time. It doesn't, it's like blood pressure control. Right. Blood pressure control. After that, more blood pressure control. Right. Hyperosmolar therapy, definitely not the first thing, right? But blood pressure control here, reversing the coagulopathy, right? So I always started to think about this: what is the quickest way that I am going to be able to hand this patient off to the neurosurgeon with a bow, right? Say that, all right, it's already been done, right? So you want to always make sure in critical care that when you are bringing a patient to the operating room, there's like nothing left that could have, should have, or would have been done that wasn't done, that you got to wait for anesthesia to do, right? And so to me, that's sort of, you give instructions to the transferring facility, you're there when the patient gets there. And if there's any delay, that's your advantage, right? That's your time to make sure that you have that you're not, detracting from the time that in the OR with anesthesia. So you put in your invasive blood pressure monitoring. It's easy enough, right? Get some central venous access because it's going to be a big case. Make sure that all of the things that you had requested were actually done, right? So whether it's, I always say hang cardian and attach it to their veins, right? Just even if they're not hypertensive, that you have it for transport, but you want to be in a situation where that you could sort of say, well, I already did that, right? And I think that I think that this case in particular, I was in sort of in the OR, and Dr. Vez was talking to the anesthesiologist, and he said, well, why don't you give some mannitol? I was like, I already did that, unless you want to give more, right? Or why don't you give some care? We already did that, right? So that's where I think that you try to teach the fellows that that's the situation, that's what you wanted. You already did that is always the right answer, right? I think that in many ways you have this sort of, and having that understanding of hemodynamics in general, right? Being able to put a probe on someone's heart even when they have a subdural, right? And understanding sort of what is the overall global ejection fraction, right? Where does it? And I think that tells you a lot. A very weak beating heart, with a high blood pressure, it's probably not that acute, right? But again, patients with acute neurological injury, a very high proportion of them will actually have significant, cardiac dysfunction. That's classically described sort of in your subarachnoid hemorrhage population with stress-induced cardiomyopathy, right? But it's a real thing. So just coming back to sort of the critical care models, if you will, right? This concept of an open and closed ICU. I don't know what a lot of this means per se, right? But this is actually an interesting study that looked at two very similar hospital systems, right? One of them implemented this, intensivist model where they had dedicated intensivists that were actually not there 24/7, but they had dedicated intensivists that were specifically trained in critical care, that were board certified, and just using sort of leapfrog guidelines, so 8 hours in house, et cetera. How did they compare to that open ICU model? And I always think back to my first day at Cape. I thought it was like a Motel 6. I'll never forget someone coming down in respiratory distress. Like I called the pulmonologist in his office, waiting for a call back. I had no idea. Like, why are you calling the pulmonologist? That doesn't make any sense. Like this patient's right in front of us for respiratory failure, right? But again, it wasn't too long ago, right? So this stuff does still exist. What's the role of things like to be innovative here at tele-ICU? How do we sort of embrace the technology we have now to be able to, to provide these services to everyone, and whether rural or urban, doesn't matter, right? So I think that that when you look at the left and the right, as far as what your sort of overall, quality metrics that improve that you're looking at, right? Again, days in the ventilator to me are very, very important. So what's the care gap here, right? So like, why is it that why is it that GNI can come in on a Monday or on a Tuesday, let me reframe, right? And then that with the previous week, you had a different group of neurosurgeons, different protocols, sort of different mindset, if you will. And then on you have a changing of the guard, if you will, so something that has a clearly defined vision for patient care, right? Sort of how do you turn around results very quickly, right? And to me, it's by identifying care gaps and then jumping on them, right? So this model of everyone shows up at 8 o'clock, you have the hospitalist there, you have the case manager there, you have the physical therapist, you have the bedside, and everyone is there, right? From start to finish. And I think you look at the data about neuro-EDs and things like this is coming, right? This is coming. It's coming here. It's probably coming elsewhere. And I think in 10 years, you give the same talk, said, why were we not doing that, right? It's been shown to be very effective, right? And I think that one service line model to me is the mecca, right? It's sort of it's that call where you get a patient that's being transferred, you meet them in the ED, up into the ICU, then into step down, and then you follow them, whether it's I myself am credentialing at the acute LTAC, right? So you're following them even to the point of post ICU discharge clinics. Things like this truly really important to me to sort of really get a good understanding of the entire trajectory, the continuum, if you will, of these diseases, right? Again, we're always talking about mortality benefit this and mortality. There's mortality benefit I can guarantee you to when I am able to pick up the phone and just call Tyler and ask him a question, or call Rudy and be like, "This is what I got in my exam. What do you think?" Right? Being able to have that conversation very freely, and I'll tell you, I remember the days of not feeling that way. It's not a very good existence, right? But there is mortality benefit to that, right? There's cost benefit. There's less studies, right? There's better length of stay. Patients do much better. I'm happier to come to work. Everyone else around me is probably happier to come to work. And I think that these are really important team dynamics to keep in mind here too. I want to talk about the second case here. I thought was just fascinating here. It was again another weekend I was on with Tyler, and it was there was again really nice guy. He came in he was a Hunt test 2, maybe I think Fisher 2 at aneurysmal subarachnoid hemorrhage. So he had a very large MCA aneurysm that ruptured. And I remember sort of, what was in the control room watching Tyler come out, noticing he didn't have great reception. So I wanted to buy him a cell phone. But other than that, making phone calls to Bez, to Rudy, to even to people who trained him up in Buffalo, some really well-known people to sort of run by him, his concern about this very large lenticular striate branch coming off of this aneurysm and sort of how he was going to deal with it. And I sort of remember thinking to myself, this is a Saturday morning in Atlantic City, New Jersey. You don't got great cell reception. It's you, right? You can call and ask you, like, you're going to call and you're going to run it by, by other people that trained you, other people with, experience. But it's you, right? So you got to support that. You have to embrace that. You have to make it so that nothing is a headache, right? And that you make it so that your colleagues in neurosurgery are actually getting better at what they do every day, right? Because they're less sort of distracted with what's going on in the ICU, right? They're less sort of distracted with who gets downgraded and when, right? They're just focusing on perfecting their craft. Right. So to me, it's like my expectation, it really should be that everything's already been done. Right. So like subarachnoid hemorrhage to me is one of the most, interesting disease processes in the neuro ICU to deal with for many different reasons. I find it interesting. But for the most part, right, what's my job is when you have a ruptured aneurysm before it's secure, it's blood pressure control, right? And after that, more blood pressure control, very good blood pressure control, if I didn't say that yet, right? But then ICP precautions, basic stuff, right? Like don't have the patient be lying flat, like avoid, choose your hyperosmolar therapy wisely, right? Try to kind of be diligent of things, but also be very algorithmic in these cases, right? Make sure that you have nicardipine just hooked up to a pump and ready to go, so you're not chasing your own tail, things like this. So how do we get better outcomes? What do we actually do, right? So this is just some stuff I put together. I realized in making this presentation way more stuff than a lot of ICU, right? But sort of how do you identify a change in the exam, right? And then how do you convey that and escalate that? And then to me, it's like one of the most important things that you get that you get in the good ICU is multidisciplinary rounding, right? So it's like you round with the neurosurgeon from 8 to 8:30, and then you have your own critical care rounds, right? And so you're going through everything sort of meticulously and systematically, right? And everyone who you need is there. And when you have sort of pending questions, right, we have a plan for the day. And to me, it's like a plan for the day, just in my head, it's like 3 goals, right? Sometimes it's like get out of bed, it's, make sure that the EVD doesn't cloud up, things like very simple, right? But you have to have a goal, right? And you have to be able to sort of get everyone to sort of on your team to buy into what it is that you're trying to do, right? So you look at GNI, it's a very interesting sort of, model for how do you deliver, high acuity. You have to have a pharmacist who is very clinical and knows what they're doing, right? Being able to dose antibiotics when you're on dialysis, right? Being able to sort of neuropharmacology, very sort of up and coming kind of field, very important. So something that many places don't have, we don't have Atlantic here, right? GNI does. I think these are important things to kind of, give and take, if you will, right? Sort of, educate, research education at the bedside, of course, but the things that making sure that sort of your team is invested in what it is you're trying to do for the patient. And sort of, things like a checklist are very important. And incorporating these in the neuro ICU, I think will go a long way. It has gone a long way. And family involvement to me is something I'm increasingly interested in. Sort of how do you, to me, it's this concept of a digital ICU, right? But how do you sort of make sure that the family experience for something that's really tragic is like not, is enhanced here. So this QR code is actually to an app that I've been working on for, this has been I spend most of my time in the past month, but it's called neuroguideai.com. So you scan your QR code, you'll be able to get to it. And I'm working on the HIPAA compliance, but it has and my wife's a lawyer, so I went very knee deep sort of in the legal aspect of this, but to identify data in the here and now, to identify those patients that we sort of know are going to need an early tracheostomy. The literature shows benefit to early tracheostomy and durable feeding tubes, right? But being able to identify those using not only your available literature, which is okay, right? Things like the SAT score, the VISTAGE score, you'll find a lot of scoring systems, right? But how do you incorporate stuff like, I don't know, the fact, if you have a holohemispheric stroke, that's very sort of different than, a significantly smaller stroke, right? Logical thing, right? Or how about when someone gets reintubated in the neuro ICU? It's sort of a different tale than someone in a medical ICU that gets reintubated, right? It's very telling right there. So I envision this to be able to have, on your phone, which you can do now, right, and actually have the nurse who's sort of at the bedside with the family for 12 hours, sort of being able to understand that part of the treatment therapy we're going to offer to a patient, for example, with a high grade subarach or a intracerebral hemorrhage is, and that's is early tracheostomy, early neuro rehabilitation. The moment it's safe to do it, we should do it, and then we shouldn't wait a week to get a peg tube, right? And so what we'll, there's one more committee meeting, but in November we start, to train with neurosurgeons to do ultrasound gastrostomy tubes. So tracheostomies at the bedside, with the same dose of sedation and paralytics. You'll put a feeding tube in, and you refer those patients, and in a sort of very educated and kind of and a very diligent way to neurorehabilitation, right? So one of to me the most important part of a neuro ICU is the nurse, right? Recognizing exam changes and what do you do with that, right? So this is something I put together for nursing, but you have a standardized response, right? So you notice an exam change that's different than the hour before. So then what are you going to do? To me, again, it's like you're walking through gum, right? So I always order the CAT scan. Then I call in the neurosurgeon. The reason for that is in neurocritical care is different than any other aspect of critical care. My management, when I get a CAT scan, is oftentimes not that significant, whereas the neurosurgeon's management, very different, right? It will vary a lot based on the CAT scan. So if they don't want one because it's not going to change their management, there's no point in getting it. You're just incurring the right, because you got to get it done quickly, right? And I think that this is really the most time sensitive, aspect of critical care is brain injury, right? But then being able to have a sort of a protocolized way that the nurse can sort of notify the physician, making sure that this information quickly gets to where it needs to be, then it gets documented to where it needs to be, and that you have things like that you can even use NeuroGuide AI for it, right? But also then you go and you can use things like smart phrases in the EMR, right? And so this one exists right now, ... SAH exam change, right? Very simple things, but specifically, what's the exam change? What did you do, and who knows about it? So technology and innovation to me are really interesting aspects of critical care right now. Maybe it's because I'm biased. I don't want to go to work nights tonight, but tele-ICU, whether it's using Marvin the robot that we have just hanging around in the neuro ICU, the use of AI for predictive analytics here, really interesting, really, really fast. How do you individualize sort of ICP monitoring, to the individual patient? What's the difference between sort of compartmentalized ICP crisis versus general ICP crisis, right? Sort of these, and how do you take very large data sets and give it something to the individual, right? How do you create sort of, decision-making algorithms that you can use in a pinch that everyone can sort of use? So again, I went the wrong way. But again, so to me, I'd love to create what I'm calling this digital ICU, right? Sort of where patients and their families can go on their phone, look up, even as far as who is their treatment team today, who is their physician, who is the nurse, like what's the face, right? And then when we recommend tracheostomy, what is that? Like why, right? What's a pug tube, right? Like what do we mean by all of these things? And remember, these are the most traumatic and tragic moments of people's lives when you get a phone call that your loved one has a big brain bleed, things like this, right? It's very morbid, very life-changing, right? So I think that the ability to sort of digitalize medicine has lagged significantly behind other fields. And it's not been to the benefit of the patient. So embracing technology, right? embracing innovation, right? So how do you sort of, be able and there's plenty of apps out there that, for that you can calculate a stroke scale or an ICH score, a Fisher score, things like this. But how do you integrate? How do we do that for our neuro ICU sort of, and how do we make it so that compared to compared to Cooper, which is probably the next closest, comprehensive stroke, that, we can do all the stuff they do it better and make the experience better, right? And to me, this stuff is, is probably simple things, relatively simple things, right? Things like, identifying and very clearly delineating who is the patient that is going to benefit the most from early tracheostomy. What does that pathway look like? And how do we get the moment these patients are admitted to the unit, everyone's sort of on the same page. I got a person with a high grade with an ICH score of 2 for a relatively large bleed. We know they're going to need a lot of time to get better, right? So from the get-go, sort of framing that as part of your treatment strategy has got to be, early tracheostomy, and that's where, to me, length of stay is a really important metric, right? Because to me, length of stay is less ventilator days. Less ventilator days, patients always do better, but specifically in this cohort of patients, right? And so these two slides here are just sort of I data dumped a bunch of papers and a bunch of articles, actually using Subspecialty AI, and the different aspects of, well, how do you compare these different scoring mechanisms, to clinical gestalt, and what is clinical gestalt, right? And sort of, if you look here on the left, identifying which patients early on. So I mean, by day 5, you have a tracheostomy and a feeding tube, and you've got a referral to LTAC, and you have a very good idea of what insurance will and will not cover. And you're willing to dig in, right? And you dig in with that patient, right? Because recovery takes a while. To me, that's where you extend critical care beyond just the ICU, right? From start to finish, you're committed. So real-time AI. So this, a feature, again, the before it goes very too live, if you'll, right, but you get these features of it pops up on your phone when a patient, right, sort of meets would be identified as someone who would benefit from early tracheostomy, and then you could use it for other things, right? You could use it right to identify, to track things like exam changes, right? Then you can use it, and hopefully one day you sort of interface, if you will, with other providers. A lot of legal aspects to it. Didn't realize how sort of challenging some of this HIPAA stuff is to overcome. But when you set your mind to it, you could do it. You're surrounded with the right group of people, right? And then collecting data. And I think, to me, that's where this, the AI, having a good understanding of how to harness AI, how to harness technology innovation, to improve outcomes, not just things like mortality outcomes, right? Patient-centered outcomes. So again, just another pug, gastrostomy tube, tracheostomy slide here, right? But at multidisciplinary approach is really important. Quality dashboards. So that's what made the Cleveland Clinic in critical care the Cleveland Clinic, is quality dashboards, right? So we go on the GNI website, you have a very clear quality dashboard, right? You see exactly what it is your ICU can do compared to other places, right? Things like, line infections, right? Ventilator associated events, all really things that we sort of consider the, dings. I hate that word, but the dings, if you will, what they mean to the patient, right? So, the ability to sort of use technology and innovation to sort of, I decided one day, I came home at like 10 o'clock at night. I wanted to learn how to develop an app, and I wanted to learn how to write the code to develop an app so that I can digitalize the way I take care of patients. So you do it, right? And sort of here, clinical impact. So if you reduce the amount of time it takes a patient to get a tracheostomy, right? Well, that probably increases the amount of time that they don't spend lying in the supine position waiting for a peg tube. That increases the amount of time you get to sort of understand where their insurance is at, so you can get them to the next stage of care, if you will. I think there's a lot of opportunity for outcomes, sort of to improve outcomes here. And again, so it's specifically, right, the one of the things that I really anticipate, and you can use these really sort of large data sets to kind of come up with different, percentages of different, goals that you'd like to meet for your team, for your ICU, right? And so this particular model, if you will, is this version, this iteration of this NeuroGuide AI focuses specifically on the non-TBI patients. But I think the literature is even stronger for TBI, right? And we'll be in that space soon enough. But I think that your non-traumatic acute brain injury patients are the ones that we're taking care of now. So how do you sort of develop things like I keep talking about, these quality dashboards, right? This is not actually that hard to do, right? But you have it in real time, right? So basically things like protocol compliance. I cannot tell you how important that is in the cardiogenic shock space, right? Like you actually cannot deviate from protocol because you felt like it or you wanted to try something new. And if you do, you gotta explain yourself at the monthly shock meetings, right? The same thing with when it comes to, if anything more so when it comes to brain injury. Again, so expected outcomes, return on investment. Some just I spent way too much time on last night, right? But how do you sort of data dump all these various studies looking at cost and all these large data sets, and how do you sort of make sense of that? And how do you apply that to your patients that you got right in front of you, right? And then sort of how do you prove to hospital administration? How do you sort of demonstrate that this is something that and right now you have your lucrative service lines, which is cardiac and neuro, right? Probably cancer too, right? But cardiac and neuro, those are your service lines. That's the space you want to be in if you're a young intensivist, right? That's the space you want to be value building, right? And so I think that sort of you can actually project return on it, which is really interesting. But looking at the literature, making sense of it, trying to apply it to sort of when you make your own pitch for your own ICU, right? And the last thing I'll talk about is that vision I mentioned in the beginning of this blowing open these very myopic and silos that you have all around you in critical care, right? So incredibly disruptive to patient care, right? If you want to see mortality reduction, then to me the mecca here is really to one service line, right? Neuro ED. I'm always interacting with any time with the emergency room, always, right? But a neuro, I've established these protocols. We all sort of agree on it. We protocolize from start to finish, and then we hold each other accountable, right? We move the ball. We get better every day, right? So I think that these are sort of really interesting things. And this is an email from 2023 that I had sent, just looking at sort of what is the concept of a neurocardiovascular center of excellence. The grand round of was fantastic. Was and I've met Haley, but the Chiari Center of Excellence. Like, what a rare disease, but what an important concept to have a center of excellence, right? So what if there is one other neurocardiac center of excellence actually in Tampa? And then, of course, the Buffalo program, which is probably the most well known, right? But again, the term Center of Excellence exists in Tampa, Atlantic City Beach, same kind of concept here, right? But a neurocardiovascular center of excellence, to me, that's where you sort of see that's what subspecialty critical care is all about, right? Being able to align the incentives of your cardiac surgeons, of your neurosurgeons, right? And specifically when it comes to things like mechanical circulatory support, or just the fact that they're volume generating, right? Like if you have calcified coronaries, chances are you're going to have calcified, intracerebral arteries, right? And so these are things where there's no reason for the patient to go now. To me, is really important. So one of the things I really appreciate a lot about working with my colleagues from GNI is that sense of urgency, right? Like, do it now, start now. If you have a very clear vision of what it is you're trying to do, and you get up every morning and you do it, and you're doing it with like-minded individuals that sort of hold you to the same standards you hold yourself, patients will do well, I promise you. We'll do something very special. So I think that again, this is one more slide about different staffing models, right? It's really not that complicated here too, right? But ultimately, right, the key takeaway here: subspecialty critical care are been shown to have proven they're successful models. They're probably the most successful models in all of critical care. Right? The most mortality reduction is in cardiac and neuro, specifically in your post-ops, right? Embrace innovation the same way we've done with mechanical circulatory support, same way we've done with neurointervention. Embrace innovation, right? Don't be afraid to ask questions, and to challenge the status quo, right? And I'm realizing that having any gap in these is very, very dangerous for the patient, right? Having a gap in things like noticing an exam change could be the difference between a carotid shutting down and someone being hemiplegic and not, right? So I think that these are the sorts of things that, to me, make me very passionate. But I'll stop there.
Well, that was Sam. Thank you. That was fantastic, and I can tell you just by the responses and the amount of people that are always on right to the end. So that was phenomenal. I only wish we had more time for all the questions. So I'm gonna kind of, because there are several that kind of fit into the same pattern of what people wanted to questions that people had. It really revolved, not surprising, around AI, telemedicine, and how you kind of incorporate that. So I guess what's the short answer to where you see practically today doing the ideal model, but integrating AI and telemedicine in a high acuity ICU?
Yeah, right. So that's a great question, right? So to me, it's so telemedicine actually is something in critical care that we sort of look down upon, right? And in many ways, and you could probably find it online if you Google it, right? There's a Society of Critical Care Medicine thread where I asked about telemedicine billing. And the idea was that we have this robot Marvin. I have access to it on my phone, right? So like if you really want to get granular with overnight coverage, you have a really well-trained, specialized APP, right? Who is able to has all the tools right in front of them, whether it's clinical decision making AI, right? Being able to sort of interface with that provider, but also being able to get very nuanced and granular with your exam changes, right? And then being able to imaging, quickly obtaining imaging. And I remember when I was a fellow, there was a WhatsApp group. Every single stroke in New York City that went to sign, I went through this WhatsApp group, right? There was hundreds of people on it. And I thought it was one of everyone would chime in. See the same thing actually with our shock program using Tiger Text, right? I think these antiquated, these clunky sort of technologies, they're not always beneficial. And I think questioning this notion that you have to be at the bedside, but maybe that's actually not what the patient needs all the time, right?
Right. And I think also the consistency that it's not some doctors in Florida who doesn't know anything about anything is just getting through the night, where it's a specific individual that everybody knows, and there's that relationship. So in 30 seconds, just because we're over here, what is the resistance, do you think, to in 2025, around the country, a lot of places not doing bedside? I mean, most large, busy ICUs are doing bedside trachs and pegs. But what is the resistance to not only just doing them bedside, but doing them at all? Because I do think one of the biggest issues, as you know, in length of stay is getting people early trachs and pegs. What is the resistance? Is it an insurance issue? Is it a workload issue?
I think it's a great question, and the more I sort of speak to people, and just the more I sort of watch this play out for the past, really since I've been doing critical care, I will say in 30 seconds or less, I don't know, which means it's probably not a very good reason. Probably, and I think in many ways, when you think about this ultrasound gastrostomy procedure, and when you talk to the guy who had Co-Optech, who actually created the procedure, he did it in 2013. I remember him telling me, "Oh, I got mad at this for not doing a peg." Like, so you created this out of spite. He's like, "Oh, all spite, Sam, all spite, right?" So it's again, I think that's one of the better examples as to why there isn't actually a reason. So therefore, it probably isn't a problem, right?
Yeah, got it. All right. Well, listen, fantastic grand rounds. Thank you so much, and we look forward to seeing you and hearing from you again. Take care.
All right.
Thanks, everybody. And don't forget to
Okay.
fill out the survey so you can get your credits.
All
Have a
right.
great weekend, everyone.